Dr. Kim Chi. I'm a medical oncologist and professor of medicine at University of British Columbia. The aim of the MAGNITUDE study was to evaluate the combination of niraparib plus abiraterone as a first-line therapy in patients with metastatic castration-resistant prostate cancer who had been prospectively identified to be having or not having gene alterations in homologous recombination repair. The MAGNITUDE study was a randomized, double-blind, placebo-controlled trial. However, an interesting and important feature of the study is that we enrolled two separate cohorts. One cohort included patients that we called biomarker positive, that is, they had an alteration in a gene associated with homologous recombination repair, like BRCA2, and then the other cohort was what we called biomarker negative, meaning they had been tested for gene alterations in homologous recombination repair and were found not to have any. Each of these cohorts were then subsequently randomized to receive either niraparib, 200 milligrams a day with abiraterone at standard doses, versus placebo plus abiraterone. With this study design, we're really able to test the hypothesis whether niraparib plus abiraterone benefits either patients that were biomarker positive or biomarker negative. Well, the way the study was designed was that we first tested the patients that had BRCA1/2 alterations. And what we found is that there was a statistically significant and clinically significant improvement in radiographic progression-free survival. For the patients that were on the control arm, the time to radiographic progression was only about 10 months. For patients that received niraparib plus abiraterone, the median time to radiographic progression-free survival was around 16 months. So very much big improvement, but also points to that patients with BRCA1/2 alterations have poor prognosis. In terms of the overall biomarker positive cohort, there was also a statistically significant benefit with a 27% improvement in radiographic progression-free survival. I think we have to be careful with overinterpreting subgroup analyses. In the subgroups that we analyzed as per the pre-specified, there was actually a consistency of effect of niraparib plus abiraterone across all the pre-specified subgroups. We have to be careful about the point estimates and then the wide hazard ratios because these subgroups are not powered to detect differences. But statistically speaking, there was no heterogeneity, meaning again that the niraparib plus abiraterone benefit was consistent across all the groups. In terms of whether we should be starting niraparib plus abiraterone right up front as early as possible, I do agree with that. However, the study was a very pragmatic design. And we wanted to get patients tested for the genomic alterations, and we allowed patients to start on the abiraterone because that is standard of care in order to have the time for them to get the genomic testing done. We will be capturing data on the subsequent therapies. In fact, patients were allowed to get unblinded and then receive treatment as per investigator, including receiving other PARP inhibitors after they had achieved progression. So this will be a very important endpoint to look at, particularly around PFS2. PFS2 is looking at the time to progression on the next line of treatment to really address that question about, does sequential therapy, is it better than doing upfront therapy? However, I think earlier treatment is better. When we look at the PROfound study, which looked at olaparib as a single agent in patients after ARPI, even with just a 3-month improvement in radiographic progression-free survival, this translated into a very large advantage in overall survival. And I think this is because patients with homologous recombination repair genes have very aggressive disease. And the earlier we start these patients, I think the better it is for them.